Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by SurvivingBreastCancer.org. I am Laura Carfing, breast cancer survivor and founder of SurvivingBreastCancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends. It is another week with another episode on Breast Cancer Conversations. Today, we are focusing on all things radiation with two amazing radiation oncologists, Dr. Rachel Jimenez and Dr. Kim Corbin. Before we get started, I want to make sure that you have the down low on all things surviving breast cancer and breast cancer conversations. I understand that a breast cancer diagnosis can be incredibly overwhelming, and actually the amount of content and information that we put out on a weekly basis can also be equally overwhelming. But if you are looking for support, I want to let you know that we are here for you every step of the way, from weekly virtual Zoom meetups for all stages, metastatic, as well as inflammatory breast cancer. We also host monthly support groups and workshops on expressive writing, art therapy, movement Mondays, Zumba, yoga. We have a book club that meets once a month where we read books that have nothing to do with cancer. So it's actually a great escape. So all of this information can be found on our website, survivingbreastcancer.org/events. All right, so back to our amazing guest and co-host. Today is part of our MBC webinar series, co-hosted by Abigail Johnston and myself, and we are joined with Dr. Rachel Jimenez, who is an assistant professor of radiation oncology at Harvard Medical School and the chair for quality and safety in the Department of Radiation Oncology at Mass General Hospital. Her clinical practice focuses on treatment of patients with breast cancer, and she has a special expertise and interest in the use of proton radiation and the reduction of cardiac toxicity. We also are joined with Dr. Kim Corbin, who works in radiation oncology at the Mayo Clinic in Rochester, Minnesota. She completed her residency training for radiation oncology at the University of Chicago, and she is the proud recipient of the Teacher of the Year Radiation Oncology Award and the Minnesota Monthly Top Doctors Award for Radiation Oncology in 2021. She is currently a member of the Executive Committee for the Department of Radiation Oncology and the Planning Committee for the National Consortium of Breast Cancer. It is such an honor to have these two doctors on today's webinar series with us and podcast. So without further ado, let's jump right in. Welcome to today's conversation.
I'm Rachel Jimenez. I'm a radiation oncologist at Mass General Hospital in Boston. I focus primarily on the treatment of patients with breast cancer. I think what drove me into the field of radiation oncology was just that throughout my medical training, I really was attracted to specialties where patients were dealing with really serious medical issues, where they had to make really difficult decisions with their families. And I just found myself really drawn into being able to have those conversations with patients and families and think about how we prioritize most what patients value. And I think we do that quite a lot in our specialty. And I consider it such a privilege to get to do that with my breast cancer patients.
And both you and Kim work in the clinical trial space as well, correct?
Both Kim and I do a fair amount of clinical trial work. We're both at academic centers where our priority is in trying to move the needle forward, whether that's in improving cure rates or in improving quality of life for our patients who need radiotherapy. I do participate and lead a number of clinical trials specifically related to trying to mitigate the late effects of radiotherapy. And Kim and I may get to this a little bit later on, but I think we both have an expertise in proton therapy, which we think has the potential to limit late effects. And so that's been a particular interest of mine and also Kim's.
Wonderful. So Kim, would you like to also introduce yourself?
Yes, well, thank you very much for inviting me to be part of this today. Rachel is a good friend of mine, and I'm happy to meet new friends to talk with about radiation also. So I'm a radiation oncologist at Mayo Clinic in Rochester, Minnesota, where it's always winter practically, except for this time of year. It's very beautiful for us. I was really drawn to oncology from a young age, actually. So I have the kind of experience of having my brother had cancer when I was young, sort of at a pivotal time. So I got to experience that as a family member for a few years while I was in high school. And for me, that really motivated me to want to go into oncology. like many other people, I had never heard of radiation oncology before I went to medical school. I had no idea it was a separate specialty or training. But I really was seeking opportunities to form these deeper connections with patients and to be able to support them in my role as an oncologist. So because of that, in the period of time in medical school where you go through rotations, I rotated through kind of various different medical oncology, pediatric oncology, surgical oncology, and I just really resonated with radiation oncology just in terms of, the amount of education and time we get to provide to patients and taking care of patients across the ages. So I really loved it. I trained in Chicago. I went into private practice for a few years, but I missed the clinical trials, the education, and things that Rachel was already speaking to. So I came to Mayo now about 7 years ago, and I've just really loved it. I specialize in breast cancer care here.
And before we get too far along in our conversation today, I just want to clarify the terminology. Is there a difference between radiotherapy and radiation?
You probably hear us talk about them fairly interchangeably. Radiation oncology is kind of the designation for the specialty, and we talk about radiation or radiotherapy kind of as the modality that we're using.
Great. Thank you for clarifying.
Whoever wants to start to talk about, I know we've already talked about, you mentioned proton therapy. We've got all kinds of other different types of radiation, like whole brain radiation or stereotactic radiosurgery.
Gosh, there are so many different types of radiation out there. Rachel, do you want to kick us off and help us understand all of these options?
Ultimately, there's many different acronyms and phrasing and names for things in radiation, and it can be quite confusing to get through the alphabet soup of that. But ultimately, at its base, radiation therapy is most of the time just X-rays that we're delivering in the area where a patient has cancer. And so when we're thinking about patients who have more advanced disease where the cancer may have left the breast and gone to other parts of the body, we're using different types of techniques that ostensibly allow us to target that cancer as precisely as possible and to limit the normal tissue exposure as much as we can. And so the types of techniques that you were talking about are just all different ways in which we accomplish that, and they each have a given role depending on the specific details of the cancer, where it's located, how much of it there is. And so we can talk through a little bit of those pieces, but I just wanted to kind of provide that umbrella at the outset that there is a lot of this complicated jargon that comes into radiotherapy. But at the end of the day, we're trying to just accomplish the same thing, which is target the cancer and avoid treating the normal parts of the body that don't need to get radiation.
Rachel, you're so eloquent. I don't know if I could add anything on top of that in terms of that general explanation. When I talk with patients about radiation, I usually say it's the same X-rays that you get when you're getting a diagnostic scan, except they're higher energy. And I also try to communicate that it's a localized therapy. So I think you did a beautiful job of describing that. So unlike body-wide treatments, we're really focusing on a particular area, and that helps us understand both the efficacy or what the treatment may do, but also the potential risk for side effects. And that's usually how I frame the conversations.
Looking at somebody who has early stage disease where they might get the weeks and weeks of radiation to the breast versus radiation that is delivered to address metastatic disease, what are the different things that are taken into consideration there? What's the differences there?
Well, I think it's really tough to have a general answer to that question because every situation is very unique. But I think the goals of therapy when we're treating metastatic breast cancer help drive the number of treatments and the overall recommendation. And for many women who are men and women who are undergoing radiation to a metastasis, the goal is to really help them feel better, right? So it's to reduce a symptom that they're having or prevent a symptom that we expect could occur if the cancer grew anymore. And there are a number of dose and schedules that are pretty routinely used, ranging from a single treatment up to 2 to 3 weeks of treatment with the goal of helping to prevent a problem or to stabilize a symptom. And usually when I talk with patients about what one may be most appropriate, we're really thinking about everything, their whole life, their quality of life. Is there an important event that they have in 2 weeks? And can we get this treatment done in 1 week instead of 2? Is there a reason why 2 weeks of therapy or 1 week might be better than a single treatment? Or can we try a single treatment? And if it doesn't work, can they come back in a couple of months? And so we usually kind of talk through each of the paradigms and come up with what we think is going to make the most sense, kind of considering the whole picture.
And what you just described, would that be considered palliative radiation?
Yep, the way I just described that was palliative radiation, but I suppose it's important to also mention that sometimes our goals are not just to improve symptoms. Sometimes for patients who have metastatic breast cancer, but have a great response to systemic therapy and have one spot that's growing and causing a problem, we might actually choose to give a higher dose to try to prevent that spot from growing and let them stay on the stable systemic therapy that they've been on. So, someone, for example, who's on, a very stable HER2-directed therapy that they're tolerating very well, but has growth in a single spot, I might decide to give a little bit more of an aggressive treatment to try to prevent them from having to have a change in therapy. I don't know if Rachel, you do that, or if you have any comments.
Yeah, no, I think that's a great point, Kim, because, often when we're talking about breast cancer, and I'm sure this comes up in a lot of your conversations, Abigail, we end up lumping it together as breast cancer. But truly, as a physician, we think about every cancer as being so unique and individual patients of having very unique natural histories of their cancer. So depending on the tumor biology, where the cancer is, what kinds of symptoms people are having, we try to tailor the radiotherapy specifically for that patient. So to Kim's point, if we're seeing a patient who has had very good disease control with a systemic medication and just has one stubborn spot that won't go away with treatment, radiation can be a very effective way to treat that area. And then we're thinking about it as being definitive therapy for that cancer area. And certainly I've seen a number of patients, and I'm guessing Kim has too, based on the discussion, where we've seen patients go many years where they're on excellent systemic therapy, they're not having disease progression, and then they have one spot that pops up. And the medical oncologist believes that the therapy is very effective otherwise for eradicating the rest of their disease. And so we actually will go in and treat that area to definitive dose. We might not see that patient again for a year or 2 years. And they come back with, another lone spot somewhere that we can target. And I think this particular paradigm of treatment, where we're trying to provide definitive treatment to patients who have very slowly progressive metastatic disease, is an area that's very, it's getting a lot of attention right now. And I think we're really trying to understand which patients are going to benefit from that kind of a treatment. And so there's a number of clinical trials that are ongoing, that are in planning, that are completing, all really trying to answer that question. But I think right now, in the absence of that information, we're trying to do what we think is best for the patient in front of us, just based on a common sense approach. And if we see that a patient's doing really, really well otherwise, we want to keep that momentum going and try to treat the area that could potentially grow if we didn't otherwise target it.
Is that also something that is utilized with oligometastatic disease, where there's only one or two spots, treated a little more aggressively with radiation as well?
Yeah, exactly. So we can think about and often talk about patients as being patients who have oligometastatic disease, meaning a few different sites of metastatic disease, but not having widely metastatic disease. And then we can also think about patients as being oligoprogressive, meaning that they have metastatic disease, but there might only be a few areas that have continued to grow, even though they're on active therapy. And those patient populations may be totally different, and the way that they respond to treatment might be totally different. And that's really an unknown at this point. But for both groups of patients, we again kind of try to use our most common sense approach, which is if they're doing well, and we can do something to target those small areas of disease to ensure that they continue to do well and feel well, that it makes sense for us to try.
I was just going to add that this is a situation, it is a very complex area. And I think Rachel said it well. It's an area of active investigation in oncology research for sure. It's where I really rely on the team, the whole team that's taking care of the patient, talking to the medical oncologist, talking to the surgeons and other people who are engaged to come up with the most individualized approach and the one that we think is the smartest.
With early stage disease, the radiation is typically follows surgery. But for those of us who are metastatic, how do people get to you? How do patients get referred to radiation, just in a practical sense? Does it come from the medical oncologist? Does it come from other experts? How does that work?
Yeah, I think most times it comes from medical oncologists because they're probably our most frequent clinical partners just in terms of caring for patients with metastasis. There is actually a whole body of literature around radiation being underutilized for palliative care, actually. So there's a lot of people who are aimed at trying to educate, family practitioners, internal medicine doctors, or bring even more radiation oncology education to the medical school curriculum so people in other specialties can understand a little bit more about our role in taking care of cancer patients. Because unlike other specialties, radiation oncologists, we treat pediatric patients, we treat anywhere from very young to very old, kind of across the spectrum of cancer. And I think there've been some estimates that say that at least half of patients who are diagnosed with cancer get radiation at some point. So I think there's lots of opportunities for us to kind of intersect with patients and for us to really describe our role to other specialties.
And I think that's a great point, Kim, which is that because we see patients in the definitive setting and we treat them, and our presumption when we treat them is that we're going to cure them. And so they continue to go on and follow up. Sometimes what happens is that when they do progress, they are not automatically sent back to us for a multidisciplinary conversation. And so I think one of the things that radiation oncologists are trying to do is to ensure that we do have a seat at the table with the medical oncologist and the surgeon when a patient does present with a recurrence, because it warrants the same kind of multidisciplinary approach that we use in the upfront setting when patients are initially diagnosed with breast cancer. I do think that as the types of medications that we are providing patients improve, the types of therapies continue to improve, there may be even more of a role for radiation in that setting. Just as we had talked about earlier, Abigail, that, we have these patients who may have oligoprogressive disease or oligometastatic disease, and there may be an opportunity for us to utilize this particular tool of radiotherapy better or more frequently than it has been historically.
We do have a question from one of our listeners about considering biopsying those pesky areas that may be growing. Is that something that is a discussion with the team to whether we try for a biopsy?
I think it really does depend on the situation. Certainly, if there's something about the behavior of the spot that's different than the behavior of the cancer in general, a biopsy could be considered. It often just has to do with kind of the whole picture and then the safety and feasibility of acquiring tissue. So I would say not every time, but it's at least kind of always thought about.
Sure, because if there's a spot that's growing and everything else is responding to systemic therapy, it does raise the question, maybe there's something different about that particular metastasis that, it's somehow getting around the systemic therapy.
One of the questions we really wanted to dive into today was your expertise around proton therapy. Can you talk to us a little bit about proton therapy and the wave of the future?
So if that's a little bit of a loaded intro, I'll try to provide as balanced of a set of information as I can. So Kim and I both work at institutions that have proton therapy, which is a very specific type of radiation therapy. And it is somewhat of a limited resource. So it's available at about 30 centers or so around the country. And the concept behind proton therapy is that by virtue of the physical property of the beam of radiation that's entering the patient, it can provide less low dose exposure to nearby normal tissue than regular radiotherapy can. And so the idea would be that by sparing normal tissue around the area that we're trying to treat with radiation, we would then be able to spare more normal tissue and therefore spare more side effects from radiotherapy. It also, at least in theory, provides the potential to be able to retreat patients if they were to have progression of disease in an area that was close to an area that had previously received radiation already. I think that there's been a lot of hype, for lack of a better word, about proton therapy. And there certainly is a lot of research that's going on in this domain for breast cancer and a lot in other disease sites as well, other types of cancers. But I think it still remains to be seen what the true benefits of proton therapy are, which is why I think we try to be somewhat judicious about who we offer it to and when we use it so that we can learn as much as we can about it and make sure that it's of benefit to patients.
The only thing I would add to that is that proton therapy is also more complex, and it's takes longer to deliver, and it's more sensitive to certain things like small differences in soft tissue position. So it's not, it doesn't always provide an advantage for a patient, and in fact, it might make the treatment harder on them if lying comfortably still for a certain period of time is difficult. I would say that in the setting of metastatic breast cancer, the biggest role I would see for proton therapy might be in reirradiation or radiating spots that have seen prior radiation before. But I don't know, Rachel, if you have other comments or thoughts about that.
Yeah, no, I agree with you. I think there are some clinical trials that are using proton therapy to deliver very focused high doses of radiation, which is what you were getting at earlier, Abigail. So when people talk about the abbreviation SRS, which stands for stereotactic radiosurgery, or SBRT, stereotactic body radiotherapy, they're just fancy ways of radiation oncologists referring to giving high dose radiation in a very focused, controlled manner. And proton therapy can deliver those kinds of techniques just like regular radiation can. But there are some trials that are using proton therapy in these very focused, high dose ways to see if they might be able to eradicate small amounts of metastatic disease.
Thank you for that thorough explanation on proton beam therapy and the clinical trials that we can glean more information every time we are using it and understanding how it behaves. Abigail, I know we have a couple more questions from our listeners.
Questions about how many times a single spot can be radiated. I understand that different parts of the body have different tolerations in terms of radiation. So could you talk a little bit about that?
It looks like Janice, who asked this question, put the answer kind of in there. It's completely based on the number of treatments and the prior dose received. So there's no lifetime limit to radiation in terms of number of spots that could be treated in the body. And then repeat courses of radiation are often possible, but really depends on how much dose did it see before, what's the interval since the prior treatment, and what did the nearby normal tissue see. And we know that normal tissue does heal after radiation, but the way I think about it is that it never forgets the radiation it saw before. So additional courses of radiation are often associated with increased risk for having scar tissue or other complication. So we really have to be very thoughtful about that.
And with the bones in particular, does it actually weaken the bone, that the scar tissue that can develop?
Bones can be weakened as a result of radiation. It's actually quite common for bone to be weakened first by the cancer, and then when radiation is given and that kind of recovers, there to be kind of a spot that doesn't heal on its own. So it's sometimes why for long bones, we're thinking about things like prophylactic fixations or procedures to make weight-bearing bones orthopedically stable to facilitate treatment and recovery.
And that's similar to your experience, Abigail, where you actually had 2 titanium rods put into your femurs to strengthen your bones. So my question for Kim and Rachel are, when you sit down with a patient and prep them for radiation therapy, how does that conversation go? What are the types of things you are informing the patient about?
So I think it depends somewhat on what the radiation course is and what we're targeting. So most of the conversations surrounding radiation start with what is the goal of delivering radiotherapy? Is the goal to relieve pain? So a lot of patients will present to us if they have ER-positive breast cancers with bone metastases that can cause pain, or that can cause instability of the bone, and then the bone itself breaks from the cancer, and that causes pain. And so sometimes we're having conversations with patients about the possibility that radiotherapy can provide some pain relief. And in about 70% of the patients that receive palliative radiotherapy to the bone, we do expect that they will notice some improvement or eradication of their pain. In other settings, for example, if a patient has a metastasis that's involving the brain, then typically patients don't have pain, but they might have neurologic symptoms. So they could have unsteadiness, they could have nausea, they could have headaches. They can have other types of symptoms depending on the location of the brain metastasis. And then those conversations really are about controlling that particular area so that it doesn't grow and cause more neurologic symptoms. But again, it really depends on the part of the body that we're treating. So our initial conversation is typically what's the goal of the radiation? And then what do we think it will be like for you to go through the treatment of radiotherapy? Logistically, what is that experience like for you? What can you expect in terms of side effects, both immediately and long term? And then ultimately, what do we think the goal, the likelihood of success will be in this setting of treating this particular area with radiation?
Radiation, typically the side effects peak actually a little bit after treatment's done. So that's the other thing I usually talk with patients about is, when can you expect kind of the peak potential acute side effects, how to manage those, when should you call me, which is like, if you ever have a question, just call, but.
Angela has a question here about when a bone is radiated, does it affect the marrow in such a way that it lessens overall red blood cell production?
Typically, when we're thinking about irradiating a bone metastasis, we worry very little about the red blood cell count, but we can worry a lot more about people's platelet counts. And so that's the first type of blood count that can be impacted with radiotherapy. And so we do think about getting a blood count to ensure that people's blood counts are safe to provide radiotherapy. And if we're giving a course over time, we might want to repeat the blood counts. And certainly our initial concern is about platelets and about people being able to clot appropriately if we've dropped their platelet count from radiotherapy. So some of the things that we kind of are considering is what other systemic therapies has that patient received in proximity to the radiation, and how has their marrow held up with systemic therapy over time? Because sometimes what we can see is that patients who are going through systemic therapy, their marrow starts to become a little bit less robust over time, like it bounces back more slowly. And so that's something that we try to bear in mind if we're going to add on top of it irradiating the bone marrow. We also think about what bones we're irradiating because some bones produce more bone marrow than others. So specifically, if we're treating the pelvis, we tend to think more about people's blood counts and marrow being suppressed than in other types of bones in the body. So those are the kinds of calculations that we're making when we're thinking about radiotherapy. And so we often will counsel patients if we're concerned about that we might repeat a complete blood count or that we'll be tracking their counts as they go through treatment.
The one area that's worth highlighting also is actually radiopharmaceuticals, the kind of bone-directed radiopharmaceuticals that are probably used less often today than they might have been, or at least in my practice. I don't know, Rachel, about you guys, but strontium or samarium or some of the bone-directed agents, those tend to have a greater impact on the blood counts than focused radiation to a single bone site. We really do look at the baseline counts and think about the volume and the bone that we're treating. And I would say that I have rarely felt limited in terms of delivering a single dose of radiation or palliative dose of radiation to a bone site or two. But radiopharmaceuticals, on the other hand, those have made me a little bit more anxious from time to time based on the blood counts.
Yeah, that's a great point. I don't think we personally don't use a lot of radiopharmaceuticals for breast cancer, but there may be areas of the country that do. And I agree that's an area of concern because it's not an easy washout period, just like you would think about it being for a systemic therapy. So you really do need to be cautious about it.
Other questions that I see bubbling up are understanding the difference between CyberKnife and Gamma Knife. Can someone help explain those differences, what they are, and how they benefit the patient?
I can start, and then Kim, please keep me honest here. So the CyberKnife Gamma Knife conversation kind of gets back to my initial point, which is that there's lots of fancy terms and phrases in radiation that make things needlessly complicated, and that CyberKnife and Gamma Knife are still just ways of delivering radiotherapy. CyberKnife just mounts the radiotherapy on a robotic arm that can move around the patient, but the radiation is still the radiation. And Gamma Knife can use radiation. It's often used in the brain where there's small targets. So both of them can be used to try to target very focused areas of radiation and tend to be used less frequently if we're targeting a larger area of the body for radiation. But at the end of the day, radiation's radiation. They're just different machines for delivering the same thing.
Another term that sometimes people use to think about something similar is like Linux-based SRS. Again, just like more alphabet soup, like Rachel described. So really just focused high-dose radiation.
If a patient is consulting with more than one radiation oncologist, and they're recommending maybe there's different machines at different locations. How does a patient figure out which one is going to be the better one? I mean, we're talking about all these different terms and it's just radiation, but if there's different machines and different modalities or different ways of delivering the radiation, then there's got to be pros and cons. So how does a patient figure that out?
So I would hope that the radiation oncologist that's talking to the patient is having a very balanced conversation about what machines they have and why they're using the machines that they do have. And so I would say that most of the time, the technology for delivering X-rays, which is what we're talking about here with CyberKnife or Gamma Knife or a linear accelerator, which is what Kim was referring to as a LINAC, all of those machines can deliver radiotherapy pretty equally well. And some facilities have specific machines that they offer, and other facilities have other machines that they offer. But I would say it's just like any other device that any physician or any technologist has at their disposal. If they're very good at knowing how to use that device to its best use, then they typically can deliver radiotherapy very well with the machine they have. I tend to be a little bit more skeptical when people are saying like, no, you have to have Gamma Knife or you have to have CyberKnife, because again, they're just slightly different ways of delivering the same thing. And ultimately, if the radiation oncologist is knowledgeable, they can appropriately deliver radiation with whatever technology they have at their disposal. But maybe I'm just a little bit biased here, Kim. I don't know if you have different philosophy.
No, I agree with you. I mean, I think that there's a tendency in medicine to kind of oversell the technology and the technological components. And through some, advertising or the way that that reaches patients, sometimes, people end up feeling like, oh, they must have this therapy or that therapy, and that's going to kind of make all of the difference. And I think that's it's an unfair way to reach patients. So I hate when I see that happens, actually. I think in terms of sometimes understanding the difference between focused treatments in the brain, one thing that it can be different based on the technology that's used is whether there needs to be a frame placed or not a frame placed or something invasive. So sometimes the radiation technology comes with an additional procedure that might not be necessary with one machine or might be required with another. So understanding that from the radiation oncologist is the best way to understand which may be best for the patient, I think. But as Rachel said, I would really trust our radiation oncology contemporaries and colleagues out there to be the ones to help guide patients through those technologies and what their best options are.
You're talking about those masks that are actually drilled into the skull.
Correct. The frame is placed with drills, and that's not that's a bit different than a thermoplastic mask, which is a very moldable type of plastic that can be used for positioning for patients too, which is non-invasive and doesn't require any kind of drilling.
But that's actually a great point, Kim, and it hasn't come up yet, so it might be worth drilling down on, no pun intended. So when we see patients who do require very focused types of radiation, we do want to ensure that we're targeting the area of cancer very precisely. And so there are certain types of techniques where we require something to stabilize the head. Like, so for example, if we're treating a brain metastasis, we want to make sure that people aren't inadvertently wiggling their head, even if they're not trying to. And so we use this rigid stabilization where they actually do have to provide some stabilization into the skull to make sure that the patient doesn't move. And then there's other ones that, as Kim was talking about, are non-invasive, where they use essentially like a plastic mask that's kind of like paper mache. It's molded to your head, and they put it on wet and warm and floppy, like a floppy plastic mask that then, as it dries, becomes molded to the shape of your face. And that then it is snapped into or attached to the back of the treatment table that you're lying on to, again, prevent patients from moving their head. And that might be a sufficient way to prevent patients from moving. Sometimes we can't immobilize the movement of the cancer very well. And so we have to just ensure that when we deliver the radiation, that we're appropriately tracking the area that has cancer. And so one of the things that's done sometimes with liver metastases or other metastases is to put a metallic seed in the area that is near or involving the cancer, so that when we actually design the radiation plan, that we can track that area even as you're breathing or moving to deliver the radiation very precisely. So sometimes there are these extra procedures that go along with delivering palliative radiation or definitive radiation in the metastatic setting to make sure that we're really appropriately tracking that small area of cancer.
When I had the stereotactic body radiotherapy, they actually, it was actually a vacuum seal where they put the plastic and there was it looked like an attachment to a vacuum cleaner where they sucked out all the air and there was so much PSI, so much pressure per square inch that held me very still. And that was very interesting to experience that. The one question that has come up in the chat is, what's the role of scans like MRIs, PETs, or CTs? Do you use that for your planning, for the mapping?
We often use those types of scans for the mapping or planning, especially if we're treating close to a sensitive area. If we're giving like a SBRT type treatment, for example, in a vertebral body that's close to the spinal cord is a structure I really want to protect from radiation. So having an MRI in the treatment position is something that I would use in my practice to be able to define the target areas and the organs at risk very accurately. I would say that that's one scenario. And then usually PET-CTs or other types of diagnostic imaging that's acquired can be fused with our scan. So they don't always have to be repeated in the treatment planning position, but it just depends on the exact situation, what information we're trying to use from the diagnostic scans, and whether we need to actually acquire our own scans for that. We always acquire a CT for planning the radiation specifically, but it's not diagnostic. You're in that position you're going to be in for the radiation treatment.
Abigail, I know you have the ATM mutation, and I was actually tested and got, for the BRCA2, it returned back a variant of unknown significance. So our question for our guests today, Kim and Rachel, what role does genetic testing play in developing the radiation plan?
So I'm very curious to hear how Kim manages this in her practice, but I would say that as we are testing more patients and doing genetic testing on more and more patients, we are finding more and more mutations that we never picked up before. And so ATM is one of those that we see it much more frequently than we ever have in the past, and that people are trying to pay attention to what its impact will be on delivering radiotherapy. Is radiotherapy safe? Are we going to cause so much undue side effects from radiation due to sensitivity that it would be inadvisable to give radiation? And so we don't really have robust data on that, but there have been some recent publications that suggest that patients who are heterozygous for an ATM mutation are probably quite safe to receive radiotherapy, but we do often counsel them that there is the possibility, based on what the nature of the mutation is, that they may have more robust side effects than the average person. And that is just very hard for us to predict, but we try to have that conversation up front with patients so that they can be as prepared as possible and so that they can let us know if they're experiencing anything or seeing anything that's worrisome to them. I will say that I've treated a number of patients now with ATM mutations, and my experience has been that overall, they seem to tolerate radiation just as well as the average person. I haven't seen that there's been a really robust reaction, but every person is going to be different, and the nature of the mutation may be different. And so I think as we get more and more patients into our system who have known genetic mutations that we can follow and actually track prospectively and see how they are responding to radiation, we'll be able to tailor those recommendations a lot more intelligently than we can right now.
Yeah, I really practice very similarly, Rachel. I think because we all carry sort of two genes, and if you're heterozygous, you have one deleterious mutation and one non-deleterious mutation. What the experience has largely been in terms of where the data are at for responsiveness to radiation or sensitivity to radiation, rather, is that heterozygous status seems to mean that the one gene that's producing the protein that it should be is allowing the recovery from radiation the way that it ought to be. But there are a number of situations in which we sometimes worry that radiation side effects could be enhanced. Women who have connective tissue disorders, for example, may have heightened sensitivity to radiation therapy in terms of risk for scar tissue formation. And we are always kind of, at least every time I see a patient who may be impacted by sensitivity to radiation, I'm always hopping on PubMed and seeing like what are the latest data and how can I most effectively counsel this patient. And sometimes we find ourselves in a situation where the answer is, gosh, there's a potential for an increased risk, but I'm just not sure how much. And I think patients really appreciate the honesty. You can say, yeah, here's what the data show, and I'll work my hardest to keep this as safe as possible. And let me know if something comes up or if there's any concerns. And then we just are more cautious as we follow those patients.
And how does skin color, skin tone, how does that come into play?
So, to the best of my knowledge, and you might know differently than me, Kim, but I don't think that skin tone or color have anything to do with response to radiotherapy. But sometimes when I see patients who have darker skin tones, I do counsel them differently about side effects of radiation as it relates specifically to radiation dermatitis. And this is more of an issue in the definitive setting where we're giving longer courses of radiation and where we might be specifically targeting the skin. Because the melanin in the skin actually surrounds the hair follicle. And so if we cause a lot of damage to the skin, sometimes what can happen is there can be some sloughing of the skin. And so underneath the superficial layer of the skin, it's very pale. And so then as those patients are healing, it can take a while for the melanin to essentially start to migrate again out of those hair follicles and refill in the pigment throughout the skin. And so those are patients that I tend to counsel more extensively about what they can expect from a cosmetic standpoint. That doesn't tend to happen as often in the metastatic setting because, to Kim's point, we're often using shorter courses of radiation that are not specifically targeting the skin. We tend to see less skin side effects with most of those treatments. But if I think it's a concern for a patient, particularly if they have skin metastases that I'm treating, sometimes we'll see that, I do try to counsel them about realistically what it'll look like and how long it'll take for their skin to return to normal. And some of those patients will have some permanent changes to pigment, either hypopigmentation, meaning like slightly lighter than their baseline pigment, or hyperpigmentation, meaning slightly darker than their baseline pigment. And that it's a concern for all patients, but tends to be a bigger concern for patients with darker skin tones.
I think one thing I hear patients say a lot is, especially women who have fair skin tones, that they're quite sensitive to the sun, and they wonder whether that will predispose them to a sensitivity to radiation. And I assure them that the type of UV exposure from the sun is quite different than radiation, and it doesn't impact your sensitivity.
During radiation, though, it's typically recommended not to be in the sun as much, just because your skin it's been affected by the radiation.
Correct.
And so not as good to be out in the sun, right? Okay, just
Yeah,
wanted to
and even after, I always tell my patients that their skin will be more sensitive to the sun in the future, so to be very cautious. I mean, in general, all of us should always be covered up when we're outside, right? It feels like, but in general, in the future, I also tell patients to be cautious about the places that we've treated with radiation in terms of direct sun exposure, making sure they're using sunscreen or clothing where possible.
We've covered a lot of topics today. What, in your opinion, is the most exciting thing happening in radiation today?
I think the most exciting paradigm shift we've seen in radiation for breast cancer over the last, 10 plus years and kind of moving into the future is really trying to right size the treatment. And so that's sort of my way of explaining, we're trying to figure out, are there some women who've had a lumpectomy, for example, who don't need radiation that we've always traditionally treated with radiation? So are there some scenarios where we may be able to avoid giving treatment? And those studies are ongoing. And then similarly, are there women who have cancer cells that are so resistant to the current therapies that we need to intensify the therapy? So there's studies going on in that space too, in terms of adding additional agents during radiation therapy to make the treatment more intense. And so there's lots of studies kind of that fit this paradigm. But for me as a physician, it just feels so nice to know that, 25 years ago, if you showed up at the doorstep for a radiation oncologist having had a lumpectomy, no matter if you were 20 years old or 80 years old, you're getting 6 weeks of radiation. And that's not the case anymore at all. Now we're offering 5 days of whole breast radiation. We're offering partial breast radiation. We're offering these de-escalation approaches for women who've had great responses to chemotherapy. We're offering intensified approaches for women who've had less good a response. So from my perspective, clinical trials are the only way we can move forward in trying to kind of make those personalized recommendations. So I'm a big supporter of engagement with trials and designing trials that matters to patients, right? right? So it's not just like the question that the doctors want, but it's the questions that the patients want too. Like we want to make the therapies more tolerable, to better fit the cancers that you have at hand.
That was a perfect answer. I'm not sure that I have much to add to that, except to say that I do think at this point in oncologic care, at least in the United States, there's so much more of a focus on what matters to patients than has ever happened before, which is not to say we can't continue to do better. But I think that it is really refreshing to see that clinical trials are being designed with patients' concerns in mind as we de-escalate care or escalate care, depending on the particular scenario, that we have patients' input and feedback and ideas so that we make those clinical trials not just robust from a science standpoint, but convincing to patients, compelling to patients, like addressing concerns that they really have.
So with a trial in radiation oncology, it wouldn't be a situation where the patient would get no radiation versus some sort of radiation. Is it looking at a particular type versus the standard of care, or how does that work in a radiation trial?
So it could actually be the paradigm that you mentioned, Abigail. So there's a number of trials that are looking at omission of radiation. So patients are randomized between receiving radiotherapy or not receiving radiotherapy. And I think that is actually a very challenging type of clinical trial to run because it requires patients to be I think very, very comfortable and trusting of their medical team to forego a therapy or to intensify a therapy. And so these trials where patients are randomized between no radiation or radiation are always the hardest clinical trials for physicians to present to patients. And I think always the hardest trials for patients to decide on. Because I think that if you go in to talk with your doctor and they say, you don't necessarily need to have radiation, but it won't be up to you or me. It'll be up to a computer to tell us whether or not you receive the treatment. I think that's really challenging. Just psychologically is very, very difficult. So those trials are ongoing. There's a number of trials actually that have recently met accrual that have had just that specific treatment paradigm. We'll be learning a lot in the next few years about which patients with early stage disease don't need to have radiotherapy after lumpectomy. And we'll also be learning a lot more about patients who had a pathologic complete response to chemotherapy prior to surgery and whether those patients require radiotherapy or not. So this is kind of an exciting time for breast oncologists because the entire treatment paradigm, the way that we think about treating patients, is really going to be turned on its head in one way or another in the next few years.
Yeah, I agree with Rachel. One of the studies that recently met accrual was the NSABP B51 study, and it was looking at women who had positive lymph nodes who had a complete response in the lymph nodes after chemotherapy. And you could enroll in that study if you'd had a lumpectomy or if you'd had a mastectomy. And for women who had a lumpectomy, they were going to get radiation either way. But the question was, do we treat the lymph nodes or not? Because the lymph nodes responded so well. And for women who had a mastectomy, the question was, or the randomization was no radiation or radiation. And I found that for women who had a lumpectomy, it was a much easier process to enroll in the study because there was some comfort in knowing you're getting the treatment. It's just going to be a little bit different. And I think for me, it was much harder for women who'd had a mastectomy. So exactly what you described, Rachel. But other studies that we do in radiation aim at trying to understand the best dose and fractionation. So when we give radiation, we give a prescription dose, and the total number of treatments would be the number of fractions, and the daily dose and total number of fractions adds up to the total dose. And the strength of radiation is really measured both on the amount you get each day, or that fraction size, and the total dose. And what we've learned in breast cancer over the last several decades of research is that there are scenarios in which it favors us to actually shorten the overall course of radiation. So giving a little bit more radiation every day to a lower total dose for women who've had a lumpectomy, for example, is associated with not only improved convenience for patients, right? So, getting 3 weeks of radiation instead of 5 weeks, lower total cost, but actually a reduction in the risk of side effects. So, less fatigue and less cosmetic change over time. So there's a whole lot of interest in understanding whether we can do make similar types of changes in a more radical way. So further shortening the course courses for some scenarios, and in the setting of other specific situations like reconstruction, whether that's feasible. And recently a study that did shorten the course completed accrual, and we hope to know in a few years whether we can give 3 weeks of post-mastectomy radiation, for example, instead of 5 weeks.
Right, because people who are looking forward to doing reconstruction, the skin can often be affected by radiation to where reconstruction is more difficult. The skin is more, I'm not sure what the right term would be, but the skin doesn't stretch as well. Is that right?
Correct. Yeah. So radiation and reconstruction are not incompatible, but we make the journey more complex.
Okay. All right.
Earlier in this episode, we talked about how patients get referred to their radiation oncologist. What is the follow-up care like? How often do you guys see patients after they finish their treatment with you?
So I think different physicians have different philosophies about how they follow patients. Speaking personally, I prefer to follow my patients long term and to see them annually, whether they're having symptoms or not, because I am their physician. And just like I would want to be concerned about side effects in the short term, I'm concerned about side effects of radiotherapy in the long term, and just about good care in terms of following them from a survivorship standpoint. I would want to be seeing them for breast exams or, chest wall exams after treatment. But when I do see a patient who has progressed and has metastatic disease, I often like to continue to follow those patients closely as well. And I often have a conversation with them about balancing the number of appointments that they need to go to, and feeling like they are being surveyed and watched by their treatment team who knows them and knows their specific issues. So, for example, if I see a patient of mine who has metastatic disease to the bone and we treat a bone metastasis, I might say to them, look, I'd like to see you again in a few weeks to see if you've responded to treatment, if you've had pain relief. If you prefer not to come back right now because you're going to be doing another round of therapy, that's okay with me. We can check in by, a phone call or a message. But the only thing I want to impress is if you do have more concerns at any point about anything, that you just reach out. You don't have to ask the medical oncologist if you're allowed to reach out to me. Just reach out to me. And so there's a number of patients that I follow that I've been following for many years who have metastatic disease. And, every time they have a concern, they'll reach out and say, hey, can you just take a look at my scans? They're going to be coming up in the next couple of weeks. I've been having some hip pain. I just want to make sure everything is okay there. And so it's an ongoing dialogue between me and that individual to make sure that we're staying on top of their concerns. And I think that most radiation oncologists who follow their patients long-term want to foster that kind of communication and connection. Because the worst thing I can ever hear is that a patient of mine that I know really well has a surprise bad outcome, right? I never want to hear that a patient of mine is in the hospital and then I find out it's because they've been having pain for weeks and nobody knew about it and they couldn't reach anybody or they didn't know to reach me. So I really try to impress upon my patients, like, just call, just reach out. I'd rather that it be nothing, that we look at the scan, everything looks great, than that we get that bad surprise at the end.
Makes a lot of sense.
Yeah, I think being available is like such an important thing for us to or it's such an important way for us to practice in terms of being a physician taking care of somebody with cancer. I say this to my patients all the time, something similar to what Rachel says, but when patients finish radiation and we see that their side effects are going to peak a week later, the last thing I want to know when they come back for their follow-up, a month later or 6 weeks later is, oh gosh, I had a really hard time, but it's better now. I'm like, no, you should tell me if you're having a hard time, because there's almost always something that we could think about doing. And it's good for us to know what's happening with the patients in those periods of time too.
So how do you balance that desire to follow up with patients with your busy schedules? How do you balance that?
Yeah, so Mayo's model is a little bit different, I think, than what Rachel described in terms of follow-up. Our breast cancer patients do follow in a survivorship clinic that's primarily run by internists or internal medicine physicians who have a special interest in taking care of breast cancer patients. And I don't see all of the patients that they see every time that they come back for follow-up. So if they're getting scans managed and everything through the survivorship clinic, then usually I just have a conversation with a patient like, do you think an appointment with me is going to be something that you want to keep doing? Will that be valuable for you? And if they say yes, then we continue to put that on the schedule. But believe it or not, as charming as I am, a lot of times patients say, I know I can get in touch with you if I need you, and I'm really comfortable with this follow-up plan. So that's kind of the way that it works in my schedule.
Yeah, so MGH is not blessed enough to have a survivorship clinic run by internists. That's an amazing resource. And I'm so glad that patients have that, but we do not have that. So we kind of make our own, which is that there's a lot of communication that happens between the medical oncologist, the surgeon, the radiation oncologist, and sometimes even the primary care physician about kind of who's going to be the main check-in for a particular patient. And I think that comes up most often when patients are managing many different appointments, right? Like everyone's trying to live their life and do all of the things that their life requires. And then on top of that, to come in for 12 different appointments is just a burden. And so if we know that somebody's managing a lot of things and their preference would be that they limit those appointments, then we just really try to identify a point person who's going to be the person that follows with them. And I do think that patients often vote with their feet. If they have a particular connection with a provider, then that's the person they want to see. And so I definitely have patients who say to me, like, can you just be the person that I follow? Like, I'll just see you in 6 months. And I say, sure, that's great. I'm happy to continue to do that. And so I have metastatic patients I see every 3 months by their request. And they see me in palliative care, and that's who they want to follow with. I have other patients who are metastatic who say like, hey, Rachel, like if something else comes up, I'll be back in your office. But otherwise, I feel really good following with my medical oncologist and continuing with therapy with them. And so I respect that. I think, there's just so much that people are balancing on top of metastatic breast cancer in their lives. And so figuring out what works best for them, I think is, kind of the hallmark for what we should follow.
I will say that the silver lining of the pandemic has been the increased accessibility of telemedicine to be able to connect with people. Because sometimes, people do want to have that connection or maintain that relationship, but they'd like to do it from the comfort of their home and not have to make an hour and a half or 2-hour drive, especially if they're doing well or they only have one thing that they want to talk about. So we've continued to incorporate video visits. I find it's such a nice way to see people's pets and learn more about their lives and other things that we wouldn't normally get to do. So that's been sort of fun from my perspective.
This has been such a fun podcast to record. Abigail, thank you as always for moderating our MBC webinar series. And Kim and Rachel, thank you for being guests on our podcast. And thank you all for listening and tuning in week after week here on Breast Cancer Conversations. Please be mindful that all of our content and information is for educational purposes only and is never a substitute for medical advice. If you want to hang out, again, please check out survivingbreastcancer.org/events, where you can RSVP to our Thursday Night Thrivers weekly meetup, our Movement Monday classes, workshops, seminars, and so much more. We can also continue the dialogue online via social media. Our Instagram handle is survivingbreastcancer.org, all one word, and you can follow us on Twitter at SBC_ORG. Until next time, keep on thriving.